Dear friends, today we are going to discuss anti-tubercular agents. Under this particular topic, we are going to introduce to the organism Mycobacterium tuberculosis, the pathogenesis of tuberculosis, signs, symptoms, and how it is transmitted. We are also going to deal with the current drug therapy, particularly the first line anti-tubercular drugs, second line anti-tubercular drugs, newer drugs added to the second line, and the limitations of the current drug therapy. We are going to discuss in detail some of the synthetic anti-tubercular agents, particularly the first line ones, and also going to deal with the synthesis of a few. We are also going to discuss the anti-tubercular antibiotics, and we are going to touch the most important problem faced, that is the resistance developed to anti-tubercular drugs. What are the different factors responsible for the failure of the chemotherapy and treatment of TB, leading to multi-drug resistance, extremely drug resistant and totally drug resistant TB. And then in the end we are going to touch to the current status of anti-tubercular research, which are the new classes of compounds emerging out. So let us start one by one discussing these topics. To see the introduction, TB infects 1/3 of the world population, and it's estimated that by the end of this year 150 million will get sick and 36 million may die. Most suffering are the underprivileged population of the third world countries, mainly due to crowding, poverty, malnutrition, and many families having single earning males, so economic burden. Worldwide, TB ranks as the 10th most common cause of deaths, and it kills 18 out of every 100,000 humans annually, making it second only to HIV/AIDS among lethal infectious diseases. 5 countries which have recorded the largest number of cases include China, unfortunately India, South Africa, Nigeria, and Indonesia, all third world countries. More people in the developing world contract tuberculosis because of compromised immunity and metabolism, and due to very high rates of HIV infection. Let us deal with the organism. TB is caused by the Mycobacterium tuberculosis bacilli, a small non-mortal bacillus. It is primarily a pathogen of mammalian respiratory system because it is highly aerobic. It typically attacks the lung but can also go to the other parts of the body and cause TB there. It has an unusual waxy coating of mycolic acid on its cell surface, which makes it impervious to gram staining, and therefore it has to be detected by acid fast technique. As I told you, it is highly aerobic and requires high level of oxygen, so therefore it first attacks the respiratory system where there is abundant oxygen supply. The cell wall of the Mycobacterium is a complex peptidoglycan, and 60% of this cell wall is lipid in nature, and this comprises of 3 major components: mycolic acid, cord factor, and X.D.R. How the pathogenesis of TB occurs is very nicely explained in this figure. The infection of a host by Mycobacterium tuberculosis is initiated by inhalation of air drops containing the bacilli from the cough, sneeze of the infected person who is in close vicinity. The organism then spreads from the site of infection to the lungs, and then through the lymphatic and blood circulatory system it goes to the other parts of the body. Once in lung, the body defense mechanism works, and these bacilli are subjected to phagocytosis by the resident macrophages of the lung, and majority may get phagocytosized depending on the health status of the person. However, some of the bacilli are able to escape the lysosomal delivery system and survive, and these can then either remain in the lung causing lung TB or are disseminated to other organs in the body, and you get other types of TBs, particularly the bone TB. Some of the signs and symptoms very typical of TB infection are chronic coughing with blood appearing in the sputum, and also you can see that there is a chest pain or pain with breathing or coughing. There are chills, repeated chills. There is also fever, temperature rises. Suffering persons get night sweats. There is a loss of appetite and therefore weight loss. The patient gets tired very fast, fatigued, and sometimes significant finger clubbing may also occur. The diagnosis relies on radiology, chest x-rays, as well as microscopic examinations and microbiological cultures of the body fluids. The latent TB, there are two types of TB, very active TB and latent TB. Latent TB mostly relies on the tuberculin skin test or blood test, and the most frequently used diagnostic methods for tuberculosis, particularly the active one, are the tuberculin skin test, acid-fast stain culture, polymerase chain reaction, and of course radiology. How the disease is transmitted? When people with active pulmonary TB cough, sneeze, speak, sing or spit, they expel infectious aerosol droplets 0.5 to 5 micro moles in meters in diameter. A single sneeze can release up to 40,000 droplets. Each one of these droplets transmits the disease. Since the infectious dose of tuberculosis is very low, even small number of droplets will suffice, and even 10 or more bacteria may cause infection. Person with active but untreated tuberculosis may infect other 10 to 15 or more persons per year. Transmission generally occurs with persons or patients carrying active TB, while with latent infection it is not thought to be still contagious. So mainly through the droplet infection by sputum positive patients with the pulmonary TB, coughing generates largest number of droplets of all sizes, and the frequency and the vigor and the intensity of the cough, as well as the poor ventilation of the environment, may influence effective transmission of the infection. Now let us see the current drug therapy and its limitation. Long-term, all therapies are very long-term, somewhere starting up to 6 months to going to 24 months. Then generally they are combination drugs required to cure the disease without subsequent relapse, as well as for prevention of death and prevention of transmission and resistance development. In the initial intensive phase, it is rifampicin, INH, Isoniazid, pyrazinamide, PZA, and ethambutol ETB or Streptomycin is given daily for 2 months, and then after 2 months a continuation phase of Rifa and INH for further 4 months, either daily or 3 times a week. As the current treatment protocols are lengthy, usually 6 to 9 months, they are vulnerable to incidences of side effects, unsatisfactory patient compliance, and slow improvement, thus making the cure rates very low. Inevitably, as this complex therapy is administered under less than ideal conditions, Drug-resistant forms of the disease have become increasingly common, leading the WHO to declare M.D.R a global threat and strongly recommending D.O.Ts. We'll see what is D.O.Ts in the next slide. Present efforts are on improving treatment by either shortening the length of the treatment by using innovative drug delivery strategies or addition to alternative administration routes or both. These efforts are likely to improve the efficacy of anti-tubercular chemotherapy, thereby enhancing patient compliance. Now let us see what is D.O.T. D.O.T, the long form, is directly observed therapy, means taking the drug treatment under trained healthcare worker or other designated individual, but should not be from the family, who provides the prescribed drug, TB drugs and watches the patient swallow every dose. So ensures D.O.T is the most effective therapy for making sure patients take their medicine. First it was done in USA in the Mississippi state, and now it is recommended by the Centers of Disease Control and World Health Organization as a standard protocol for treating TB. Advantages of D.O.T are that it helps finish TB therapy as quickly as possible without unnecessary gaps. There is no break. It helps prevention of spreading of TB. It decreases the risk of drug resistance resulting from erratic or incomplete treatments. D.O.T increases or decreases the chances of treatment failure and relapse. A nurse or other trained health care worker from the patient's county public health department normally provides D.O.T. Broadly, we describe the antitubercular drugs into two categories: first line drugs. So you start your treatment with first line, namely 4 drugs: Isoniazid, rifabutin, ethambutol, pyrazinamide, and there is also an antibiotic called as Streptomycin. Second line drugs are clarithromycin, ciprofloxacin, capreomycin, cycloserine, kanamycin, amikacin. So let us see the 5 first line antitubercular drugs: INH, Rifa, PZA, ETMB, that is ethambutol, and Streptomycin are the 5 first line agents for the treatment of tuberculosis, whose mechanisms of action are depicted and elaborated in the next slides in figures as well as tables. Of these, INH and rifampicin are the most active drugs. This combination administered for 9 months will cure almost 95 to 98 cases. The addition of pyrazinamide to an INH-Rifa combination for first 2 months allowed total duration therapy to be reduced to 6 months from 9 months. So rifampicin, the mechanism of action, it inhibits the RNA synthesis, bacterial RNA synthesis, binding to the beta subunit of the bacterial DNA dependent RNA polymerase, and therefore the chain reaction to the RNA synthesis is blocked. Isoniazid has its lethal effect on the inhibition of the synthesis of mycolic acid through formation of a covalent complex with an acyl carrier protein and a beta ketoacyl carrier protein synthesis. Thus it stops the synthesis by blocking these 2 important molecules. Pyrazinamide inhibits the growth by lowering the pH in the immediate surroundings, as well as inhibition of translation, which is a key cellular process for managing damaged proteins and rescuing non-functioning ribosomes in Mycobacterium tuberculosis. It is also an anti-metabolite of nicotinamide therapy, interfering in the anhydride synthesis, and therefore it inhibits the short-chain fatty acid precursors required for the bacterial cell wall synthesis. Pyrazinamide is actually converted to pyrazinoic acid, and which actually lowers the pH. So pyrazinamide can be considered as a prodrug. Ethambutol inhibits mycobacterial arabinosyl transferases, which are again involved in the cell's wall synthesis through the polymerization of D-arabinofuranose to arabinoglycan, which is an essential component of the cell wall. And the aminoglycosides like streptomycin act as irreversible inhibitors of protein synthesis through binding to specific 30S subunit ribosomal proteins. They inhibit bacterial topoisomerase 2, that is the DNA gyrase, and topoisomerase 4, and thus inhibit bacterial DNA synthesis. This is nicely explained in this figure. Isoniazid blocks the mycolic acid synthesis. Ethambutol inhibits the cell wall synthesis by blocking the arabinoglycan and peptidoglycan synthesis. And pyrazinamide disrupts the plasma membrane and the energy metabolism, and also the ATP formation required to supply the energy for cell wall synthesis. And your rifabutin inhibits RNA synthesis, okay, blocking the RNA polymerase and DNA gyrases. And the aminoglycoside antibiotics like the streptomycin inhibits in the translation of messenger RNA, mRNA, which leads to the formation of the, through translation, the formation of ribosomal protein or the complex, which is finally leading to the protein synthesis. So it picks up, blocks one of the 30S subunit involved in the synthesis of the this complex, and which finally becomes the proteins. Let us see the second line anti-tubercular drugs. According to WHO, there are 6 classes of second line drugs used in the treatment of tuberculosis, and this can be classified as second line because of the following 2 reasons. They may be less effective than the first line drugs, and they may have more toxic effects. And these are the following classes: aminoglycosides like amikacin and kanamycin. Okay, then you have polypeptides like capreomycin and vancomycin, and fluoroquinolones like ciprofloxacin, levofloxacin, and thioamides like ethionamide, prothiamide, again antibiotics like cycloserine, and of course para-aminosalicylic acid, which is also called as M.O.A.s. The mechanism of actions are given in this table. Streptomycin interferes with the RNA translation, inhibits the protein synthesis. Capreomycin inhibits protein synthesis by binding to the 70S ribosomal unit. Ethionamide inhibits the mycolic acid biosynthesis. Para-aminosalicylic acid inhibits the folic acid synthesis by acting like a anti-metabolite in the conversion of dihydrofolate to tetrahydrofolate. And then fluoroquinolones inhibit the activity of both DNA gyrase and topoisomerase 4 enzymes. Kanamycin inhibits the protein synthesis by binding to the 4 nucleotides, 16S RNA and a single amino acid of protein S12. And amikacin inhibits protein synthesis by binding to the 30S ribosomal subunit. So this is a glossary of the first line, second line, and additional second line drugs. Isoniazid, rifabutin, pyrazinamide, ethambutol, streptomycin can be considered as a first line. Thioacetone, M.O.A.s, ethionamide, cycloserine, kanamycin, capreomycin, amikacin are used as second line, and depending on the resistance and other situations to the second line, These drugs are also added, mainly the quinolones like ciprofloxacin or floxacin, the antibiotics macrolides, clarithromycin, azithromycin, and the rifa family analog of the rifampicin, rifabutin. The WHO recommends these therapies with the durations to start with INH, rifa, and pyrazinamide for 6 months. And if you are not taking pyrazinamide and only INH, rifa, then 9 months. Rifa, ethambutol, and pyrazinamide for 6 months. Taking only rifa and ethambutol, then 12 months. INH and ethambutol for 18 months. And all others like M.O.A.s, ciprofloxacin, streptomycin for 2 years. Standard treatment regime is comprising of 2 phases. Intensive phase, first is very strong attack by the drugs, and then continue once you have ensured that you have taken care of the disease to a significant level. Still not to take a chance, there is a continuation phase. So the goal of the intensive phase is to quickly kill the rapidly dividing organism, to control disease and render patient non-infectious and prevent emergence of drug resistance. And this is achieved by for first 8 weeks by giving these 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol for 8 weeks daily and in 14 doses. And if you are in the hospital, daily taking the smear for its negativity, and then after continuing it for next 6 weeks, or 5 days a week, 30 doses, as per the WRHA, National Agency, International Health Agency, or 3 days per week for 6 weeks, 18 doses, unless drug resistance is suspected. If you suspect drug resistance, then increase the duration 5 days per week. Ethambutol can be dropped if the organism is unsensitive to it. Continuation phase, sterilize. The purpose is to sterilize the lungs by killing dormant and semi-dormant organisms and to prevent relapse. And DOT allows for intermittent therapy. Twice weekly INH and rifampin through DOT. In intensive phase, INH and rifampicin kill rapidly dividing TB, and this pyrazinamide works to kill semi-dormant TB in the acidic environment of the cavity or in macrophages. Ethambutol is used to prevent emergence of rifa resistance when primary resistance to INH may be present. And in continuation phases, the combination of INH and rifampicin kill any remaining rapidly dividing cells as well as sterilizing fibrotic areas. So this is an algorithm for the tuberculosis therapy. If the symptoms, clinical symptoms, give a high suspicion for active tuberculosis, then first check the chest X-ray and also do the acid-fast bacilli smear test for continuously 2 months and start the therapy with INH, rifa, ethambutol, and pyrazinamide. So for 2 months you have to do this activity. And if you find that there is no cavitation after 2 months, still you have to continue with INH, rifa at least for next 4 months. And if you have some doubts after 6 months, then still you have to continue it for next 3 months, albeit you can, instead of taking 5 days a week, you can take the drugs for 3 days a week. But in case if you find after 2 months there is cavitation in the chest X-ray or positive, then continue this very actively till at the end of 4 months you get the culture negative, and still to eradicate you continue this INH-Rifa combination for next 2 months, so total 6 months therapy. But if you find that the culture is positive even after 4 months, then continue it again for 6 months. Again check, if no cavitation is there, stop it after 6 months. If you find cavitation, go up to 9 months. We are now going to discuss a few synthetic anti-tubercular agents. Isoniazid, isonicotinonic acid hydrazide, also called commonly as INH, used for treatment of tuberculosis, particularly acute tuberculosis, and often used together with the other first-line drugs like rifabutin, pyrazine, ethambutol, or streptomycin. For latter tuberculosis, it is often used alone. It may be used for atypical types of mycobacteria like Mycobacterium avium, Mycobacterium kansasi, and Mycobacterium xenopi. It is usually taken by mouth and sometimes may be given by intramuscular injections. It works in part by disrupting the formation of the bacterial cell wall, which results in the cell death. It's only acting on the mycobacteria, doesn't affect the normal cells, interferes with the mycolic acid synthesis, which is very unique to the mycobacterial cell wall, passes freely to mammalian cell wall, doesn't affect it, effective for intracellular organism, bacteriostatic for resting or dormant organism, and for multiplying or active organism it is bactericidal. The synthesis is a very simple, straightforward synthesis, starting from isonicotinic acid, and the first step involves the acid catalyzed esterification with ethanol to get its isonicotinic acid ethyl ester, and next is conversion of this ester to the hydrazide by the action of hydrogen hydrate in ethanol and reflux, and the mechanism is also very straightforward, and many times these reactions can be two-step reactions can be done in one pot. Phase transfer catalysis helps to take it to maximum yield and cut down the time. Adverse effects of INH is hepatotoxic, polyneuropathy, rashes, and some hematological like anemia, etc. Other side effects are increased blood levels of liver enzymes, numbness in hands and feet. Serious side effects may include liver inflammation and acute liver failure. And sometimes to reduce this risk, pyridoxamine or vitamin B6 is to be given concomitantly. Ethionamide is basically 2-ethylpyridine 4-carbothiamide. Ethionamide is specifically used along with other antitubercular medicines as a part of a second-line medicine, and particularly to treat multidrug resistant tuberculosis. It is believed to work by interference of the mycolic acid synthesis. Side effects, if it is taken by mouth and has higher recurrence of side effects like nausea, diarrhea, abdominal pain, and loss of appetite, mainly because of the sulfur moiety. Serious side effects may be liver inflammation and depression, and contraindicated with person having hepatic problems or having drinking habits, and also it is not recommended in pregnancy. Ethambutol is basically ethane 1,2-diallyl dibutanol. Only the S isomer is to be used. R isomer is toxic. Primarily is a first line drug given in combination with INH, Rifa, and pyrazinamide, and is taken by mouth. Mechanism is not very clear, but maybe by the virtue of inhibition of arabinosyl transferase, an enzyme that polymerizes arabinos to arabinan and then arabinogalactan, which are the component of the cell wall of the mycobacteria. Side effects is impaired vision, joint pain, nausea, headache, and fatigue. Other may include liver problems and allergic reactions. Not recommended for patients with optic neuritis and kidney problems, renal failure, or to younger patients below age of 5. Also, the contraindication during pregnancy or breastfeeding is not very clear. Pyrazinamide is pyrazine 2-carboxamide medication to treat tuberculosis. Again, a first-line drug used with Isoniazid and either with ethambutol or streptomycin. Not recommended for latent tuberculosis taken by mouth. It is, as I told you, is a prodrug of pyrazinoic acid. Diffuses in the granuloma of Mycobacterium tuberculosis, where the bacterial enzyme pyrazinamide converts it into pyrazinoic acid. Its side effects are nausea, loss of appetite, muscle and joint pains. More serious effects are gout, hepatotoxicity, and sensitivity to sunlight. It is not recommended in those with significant liver disease or porphyria, and is not clear whether it is safe or not during pregnancy and breastfeeding, so not indicated. Para-aminosalicylic acid, also called as 4-aminosalicylic acid, or in simple words called as PAS, is primarily used to treat TB. It's basically a second line medication, anti-tubercular medication, particularly to treat active and form of tuberculosis, particularly the resistant one. It is also a second line agent to sulfasalazine in other types of disorders like inflammatory bowel disease like ulcerative colitis or Crohn's disease. It is typically taken by mouth. PAS is shown to be a prodrug and is incorporated in a folate pathway by dihydropteroid synthase and dihydrofolate synthase to generate a hydroxyl dihydrofolate entamolopatalite, which blocks the dihydrofolate enzymatic activity. It fools it to the DHFR enzyme. So it is an anti-metabolite by action. Side effects are nausea, abdominal pain, diarrhea, and of course liver inflammation and allergic reactions. Not recommended with the renal disease patients. It's not recommended also during the pregnancy. And let us see its synthesis. There are two syntheses found in the literature. One starts with the 5-phenylazole salicylic acid, sodium salt, which is reduced through dithionate reduction to the PAS under alkaline pH. Now this entire process, detailed process is found in the Fundamental Process of Dye Chemistry book by H.E. Flares David. It's an old reference. Another one is, of course, more latest one of 2013 by Japanese co-workers, which is a modified Kolbe-Schmidt reaction of metahydroxyaniline, introduction of the carbonyl group to the ortho position of the OH to give PAS, and this is done through the enzymatic media. The reaction conditions involve alkaline conditions of potassium bicarbonate, water at room temperature for 9 hours using a molecular sieve and maintaining the pH to 6. Finally, then maintaining the pH is almost neutral, and then when it comes to 6, then boil it for 10 minutes at 90 degrees centigrade. Some antitubercular antibiotics, rifampicin is a polyketide belonging to the chemical class of ansamycins. These are called ansamycins because they have a naphtha-quinone core which is surrounded by aliphatic ansa chains. So this is called as ansamycin, and this chromophore naphtha-quinonic chromophore gives it a typical red-orange crystalline color. It is actually obtained from the soil bacterium Mycobacterium rifamycinica, and this particular azapiperazine and methylpiperazine moiety is a typical group for rifampicin, and this can be modified to get the other derivatives, active derivatives like rifabutin. Rifampicin is also commonly called as rifampin and is an antibiotic used to treat several bacterial infections besides leprosy, also Mycobacterium avium complex and Legionnaire's disease. These three types of diseases are also treated besides tuberculosis. It can be used with other antibiotics, except in case of Haemophilus influenza it is used alone, and it is to be used by caution when you give to a patient for a long-term therapy. Regular measurements of liver enzymes and blood counts are recommended. It is either taken orally or intravenously. It blocks the DNA dependent RNA, inhibits the bacterial DNA dependent RNA polymerase, and it is bactericidal against both gram-positive and negative bacteria, and it kills the intercellular organism. Liver toxicity, liver failure, respiratory breathlessness, skin reactions, abdominal pains and cramps, chills, fevers, headaches like flu-like symptoms are the common side effects. And sometimes it may also penetrate the blood-brain barrier to cause malaise and dysphoria in smaller age patients. Other common allergic reactions are rashes, itching, swelling of the tongue or throat, severe dizziness and breathlessness. Rifabutin is another derivative, as I told you. That N-methylpiperazine moiety has been replaced with the spiro imidazoline isopropyl piperidine moiety, and particularly used for patients with HIV/AIDS who cannot tolerate rifampin or rifampicin. It is again used in active cases of tuberculosis, and it also blocks the RNA production of the bacteria. Side effects are same typical side effects like rifampicin. Cycloserine is a simpler antibiotic. Chemically, it is a 4-amino-3-isoxazolinone, sold under the brand name of Seromycin, and used concomitantly with the other second-line antitubercular drugs, particularly in the drug-resistant tuberculosis. It is given orally. It has a similar amino acid D-alanine type of structure, and it works by interfering with the formation of the bacterial cell walls. Side effects are allergic reactions, seizures, sleepiness, unsteadiness, and numbness, and it is to be contraindicated for patients with renal failure, epilepsy, or having cirrhosis of liver, or alcoholics, or depression. Streptomycin is an aminoglycoside type of antibiotic, and it is used Besides the Mycobacterium tuberculosis infection, it is used in a variety of infections. It is a broad spectrum antibiotic. It works by blocking the 30S ribosomal subunits to make proteins, which results in bacterial death. For active tuberculosis, it is often given along with the first line drugs Isoniazid, rifabutin, and pyrazine. Side effects include feeling like the world is spinning, vomiting, numbness, face fever, and rashes. It's to be avoided during pregnancy. Otherwise, it may result in permanent deafness and developing baby which is not normal. It is not recommended in patients with myasthenia gravis or other neuromuscular disorders. Capreomycin sulfate is another second line antitubercular antibiotic which is generally given in combination with other antibiotics. It is also an aminoglycoside family. It is generally used in the M.D.R tuberculosis given mostly by injection. In 1960 it was isolated from Streptomyces capreolus. Side effects are similar like renal problems and sometimes even may cause paralysis and breathlessness. It is not recommended with streptomycin or other medication as it may damage the auditory vestibular nerve and also during the pregnancy and renal conditions. Last part we will discuss is the resistance to anti-TB drugs, and we see increasing occurrence particularly in the third world countries like China and some parts of Asia, and even it has gone to Australia, Africa and Latin America, including also India. It is more in Russia particularly. Why this occurs is because MTB finds its victims mostly in developing countries with degraded social and health conditions where access to medicines is limited and people cannot afford such long-term therapies of say 9 months to 2 years. Due to this long regimen duration, patient compliance is also suffered. They don't take it regularly and there are breaks. This leads to and also because the multi-drug regimen is there, this intermittent breaks lead to poor patient compliance and this leads to the development of resistance and to this misery is added the acquired immune deficiency through HIV infections, which is one of the major causes for M.D.R. There are three types of resistance: multi-drug resistance, extremely drug resistance, and total drug resistance. Multi-drug resistance, called as M.D.R.TB, refers to simultaneous resistance to at least two or more of the first line anti-TB drugs. It is a treatment. Its treatment is to be long-lasting, less effective, costly, and poorly tolerated. Two reasons are actually given for this. Primary resistance, as patient is infected and exposed to resistant strain right in the beginning itself. Secondary resistance is due to inadequate or faulty treatment regimen or drug-drug interactions or malabsorption, etc. Recommended regimens for treatment of M.D.R tuberculosis at least 20 to 24 months with drugs that are less toxic, poorly tolerated, with drugs that are toxic, poorly tolerated and limited efficacy, which cure rates in the range of 60 to 70%. Oral fluoroquinolones like moxifloxacin, gatifloxacin and levofloxacin are expensive and toxic. Injectables like streptomycin, amikacin, kanamycin, capreomycin, and oral drugs like cycloserine, thiacetazone are given as an alternate combination therapy and also are toxic, expensive, and less efficacious. Besides, the treatment duration may extend to 18 to 24 months instead of 6 to 9 months, as in case of drug-sensitive TB. Only 1% of the cases of MD/TB are getting appropriate drug treatment and still have poor outcomes. These are the various WHO suggested treatment regimens. 1, 2, 3, 4, 5, 6, 7, 8, 9 different permutation combinations with the durations lasting mostly from 18 months to 24 months. These are extended treatments. Resistance to drug, that is extremely drug resistant TB. It is extensively drug resistant TB, XDRTB, commonly defined as strains resistance to all current first-line drugs as well as any of the fluoroquinolones and at least to one of the three injectable second-line drugs, capreomycin, kanamycin, or amikacin. This is one of the major disturbing development in the resurgence of TB worldwide. The principles of M.D.R, TB and X.D.R, TB are same. The main difference that X.D.R, TB is associated with a higher mortality rate than M.D.R, TB because the options are lesser now for the treatment and there is an urgent need for novel drugs that are active against resistant strains with shorter duration of therapy. Although our understanding of the magnitude and distribution of XDR-TB is increasing, currently available reports of XDR-TB prevalence are underestimated because drug susceptible testing DST is incomplete and surveillance data are lacking for many nations because most of them are third world countries. In many low-income, high TB burden countries, poor laboratory capacity prevents culture and DST of the Mycobacterial tuberculosis, the resistant one, the X.D.R strains. Even in high-income nations that primarily contributed to the surveillance data of the WHO report, a large proportion of M.D.R cases do not have susceptible testing and could not be assessed for XDR-TB. Totally drug-resistant tuberculosis is still a more dangerous form, which is nowadays referred as tuberculosis caused by the strains resistance to all forms of first line as well as second line TB drugs, and this is a panic button which highlights urgent need for discovery and development of drugs. And I am sorry to say a couple of cases have been reported as near in Bombay also for the T.D.R.TB. There are more numbers of X.D.R and multiple number of M.D.R in this country. An account of current status of anti-tubercular drug research and the research pipelines, discovery portfolios with various research organizations worldwide is been presented here as a bullseye. And these are the phase 1, phase 2, phase 3 positions. And I happened to author a review in 2014 where I had given this pictorial graphical abstract. Mainly the dihydrofolate reductase inhibitor category, protein synthesis inhibitor categories, we have at least in the clinical trial stages we have 7 candidates and there may be more now in this coming years. We have cell wall and multi-target inhibitors. We find 4-5 drugs in the advanced trials and some in preclinical. ATP synthase inhibitors and depletion of membrane energy drugs. We have one of the promising drug called as bedaquiline, and we have DNA dependent RNA synthesis inhibitors. We have another rifabutin, rifalazil, and mostly these are all rifabutin. These are all rifampicin family. They are into clinical trials, and we have some drugs acting through unknown mechanisms. They're also there. And to summarize, then we have these first line drugs: rifampicin, isoniazid, pyrazinamide, ethambutol, and streptomycin. We have second line drugs: levofloxacin, para-aminosalicylic acid, amikacin, ethionamide, capreomycin, vancomycin. And today in the newer leads we have totally 18 categories of different structural families, which are thiolactomycin analogs, ethambutol analogs, mefloquine analogs, diazateridines, 9-benzylpurines, benzoxazines, diterpenoids, imidazole 4,5-C pyridines, tryptophan analogs, phenoxyamines, isoniazid derivatives, 1,2,4-triazoles, toluene derivatives, saccharides, quinolone derivatives, nitroimidazoles, oxazolidine-diones, nitrophenyl derivatives, and rifamycin derivatives. So, a lot of research is going on. The world is also taking seriously. This is in the end. I have a question mark, a bank provided to you with some short answer questions of 5 marks each, long answers questions of 10 marks each, and MCQs. So I hope this lecture was useful to you, and troubles are often the tools by which God fashions us for better things. One such trouble you may feel is exam, but it is a tool which actually will prepare you and fashion you in a better way. Thank you, being patient. Okay.